Hi, we're in the last of our series of unmet needs webinars, and this one is now focusing on FCS. The last three have been on FH, HOFH, and elevated Lp(a). So my name is Jill Prawer, and I'm the Rare Disease Project Manager here at FH Europe. I'm also the Chair of Action FCS, a charity I set up in the UK some years ago, completely dedicated to people with FCS. So I'm absolutely delighted to be moderating this meeting this evening. We have a great group of panelists who'll be sharing their expert experience and knowledge. And first of all, we'll just do some housekeeping rules. So as you know, the webinar is being recorded. And so it will be available on FH Europe's Foundation's YouTube channel tomorrow morning. Please submit questions to the Q&A so that you'll see down on the screen at the bottom, you'll have Q&A and chat. So if you can limit your questions to the Q&A, that's easier for us to pick up. And maybe use the chat to say your hellos and where you are. And questions we'll take at the end of the presentations. So because we've got patients talking about their experience, please don't ask them personal questions because this webinar is being recorded and it will be sent out. So just be kind of thoughtful about what kinds of questions you're asking. Just to set the context, really, it's FCS Awareness Day tomorrow, and hopefully you'll have been seeing a lot of our social media posts about taking the FCS 10-gram challenge. And I just wanted to kind of give you a brief overview of the need, why we're saying specifically the 10-gram challenge. And this is because people with FCS can't eat fats, or they can't metabolize fats, which is either because they don't have the gene to metabolize. This is the layperson's explanation, or they don't have something that another gene is stopping the action of the gene that does metabolize, or sorry, the enzyme that does metabolize. And if we eat too much fat, it goes around in our bloodstream, and then it turns into as triglycerides. That turns into chylomicrons, which then cause lots of symptoms, including the most serious, which is pancreatitis. And so recommendations. Diet is the main therapy that we have to keep to, and that's less than 20 grams of fat, no simple sugars or restricting simple sugars, and drinking no alcohol. So I say that and everyone thinks, oh, that's okay, so you do that and then you might be quite well. But actually, if you try and keep to a diet that low in fat, it's incredibly difficult. And this is what we're trying to raise awareness about, is the impacts that having this condition has on people, not only in terms of the symptoms that they experience and the kind of pain and suffering, for want of a better word, that is part of their lives, but also the effort they have to go through in order to try and minimize those symptoms, and just how difficult and exclusionary that is. So that's why we're saying 10-gram fat challenge, because we'd like you to experience, but I'll come back to that later. So on to introducing the panelists. So first of all, we'll go in order of who we're talking to. So first of all is Professor Martin Merkel, who's the Medical Director of the Endocrinology Center in Hamburg and the Endocrinology Center of Kiel. Michelle, so Scott is many different things, but he's also a patient with FCS, and he lives in the US, in North Carolina. And Michelle, you have just come in just as I'm introducing you. So and this is Michelle, who is also many different things, but she's a patient with FCS and is based in Milton Keynes in the UK. And I'm going to introduce myself as a patient as well, because I also have FCS, and I'm going to be sharing a little of my experience a bit later. So I'm Jill Prawer, and I'm from London in the UK. So I'm now going to pass over to Martin, who is going to show us some slides he's prepared. Thank you, Martin. And he'll be talking a little bit about FCS and the latest updates in the therapeutic options that are available for the FCS community. So over to you, Martin, and thank you.
Yeah, thank you very much for this wonderful introduction. Unfortunately, I'm not a native speaker, so you have to excuse my accent. And sometimes if I'm not clear, please ask. Yeah, your introduction was really great, Jill. I think I somewhat start with that. Here's my disclosure. I give talks once in a while for some fancy other people, and also for patients, as you see today. Now, at the very beginning, I would like to point out that hypertriglyceridemia, and that is what we measure as physicians, is really a very common disease. And here we just analyzed 2 times 15,000 patients who are in a hospital, just with the triglycerides. And if you look into this, you find triglycerides higher than 800 milligrams per deciliter. Now, I know UK is more modern than Germany. This is more than 10 millimole per liter. So if I translate it, it was 1 to 100 in men and 1 to 500 in women. Now, this is kind of my awareness slide for physicians saying, okay, guys, hypertriglyceridemia is very common. And if you have such a hypertriglyceridemia, you have to think at least once whether it is a chylomicronemia type 1 syndrome, or here are all the words we are putting up. Familial Chylomicronaemia Syndrome, FCS, is probably internationally most common used. Scientists call it type 1, or some people say severe monogenetic hypertriglyceridemia for whatever reason. Now, of course, only a very small part of these patients really has a type 1 chylomicronemia. Most of them will suffer a severe polygenic hypertriglyceridemia, which is treated completely differently. However, sometimes we would like to use our medications for FCS also for those patients, but that's a different topic. And you know all about this probably better than me. You suffer from high chylomicrons, which are really big particles. It's usually monogenic or compound heterozygote. It's mostly defective in metabolism. I will get back to this a little bit later. And of course, pancreatitis is a most common problem among some other symptoms, which you may be aware of. Furthermore, fibroids are useless, and I would be very curious whether some guys of you will take fibroids. We sometimes use it, sometimes not. And cardiovascular risk, so this stands for cardiovascular, is probably not really increased. This is all very different in the polygenic hypertriglyceridemia, and the most important difference is in these patients, pancreatitis is rare, even though if they have very high triglycerides, and it usually has some secondary cause, for instance, diabetes or hyperthyroidism or something like this. Getting a little bit into pathophysiology, and we need to look into this because we are talking about therapies today, and if you want to do some therapy, you need to understand, of course, the pathophysiology. So this is a lipid metabolism, how I explain it to my patients. You don't have to memorize everything of it. Some of it I will ask later for. But here you see the exogenous lipids. Here you see the chylomicrons coming from the intestine, and these need to be hydrolyzed. And this is done by the lipoprotein lipase, and then everything goes back to the liver. The same happens to VLDL, the other part of triglyceride-rich lipoproteins. And in chylomicronemia, this complex does not work. Now, this complex, I say complex, it's not just an enzyme, lipoprotein lipase, but it's really a complicated thing. And I was very lucky to have the chance to do some scientific works with this complex and really looking into this really precisely. And here you see the chylomicrons, which are kind of connected to the endothelium by sugars, by proteoglycans, and you need many other proteins which help. Lipoprotein lipase, of course, for the hydrolysis itself, that's a key enzyme. And then you definitely need ApoC2, and then you need ApoA5 also to make the connection really nice. Another an anchor here. It's a tie between the endothelium and the chylomicrons. Is called GPI HBP1. Nobody can pronounce this long word, but it's basically a connector which holds the chylomicrons in place, and you need a lipase maturation factor which helps the lipoprotein lipase go to the endothelium and act there. And unfortunately, all of these proteins can be broken and can cause chylomicronemia if they are broken and if they are defect and if they are compound homozygote or in special combinations. In theory, this is much less common. We have to talk about, or not in theory, we have to talk about two other proteins. One is ApoC2, ApoC3, and one is this one, HPLT. There are many types of those, up to 8, and we will talk later on about HPNTL3 and 4, because they play a certain role in the therapy. And these proteins inhibit this whole complex. So if you have too much ApoC3, then you have less hydrolysis, and then you have higher triglycerides. And the same is true for this protein, HPLT3 or 4. If it's too high, you have higher chylomicrons and higher other lipids. And in theory, it's possible that you would have gain of function mutations, which also could cause chylomicronemia syndromes. I'm not aware of any patients, but in theory, this is possible. But you have to remember these two proteins, because these are our main target in therapy. And I show it a little bit later. Now, really going into the therapeutic options of chylomicronemia syndrome, and this slide kind of shows all of it. And as you will probably be aware of, these below here, omega-3 fibrates and nicotinic acids are not really useful options for FCS. In Germany, we at least don't use any of those. What we, of course, apply at this diet, and Jill was mentioning it already, less than 15% or sometimes less than 10% energy from fat, which is, for my patients at least a real challenge. Some do really well. I'm really proud of them, but some do not very well. And then this fat replacement with short or medium chain triglycerides. Now, looking into technical stuff, in an acute pancreatitis, some people, at least in Germany, do an apheresis. I'm not sure, but this is very useful, because if you're in a hospital at intensive care with an acute pancreatitis, the triglycerides go usually down anyhow, because you don't eat and take IV food and everything. But some people in acute phases do this apheresis. Now, we have several other therapeutic options. I'll get back to those later, so I'm not going through them at this point. And of course, we have the only medication which is right now available for you and for all of my patients is volanesorsen. Going a little bit back in history, and I think it's important, and I really like to show this, because I think this is a real step for medicine, this lipoprotein lipase gene therapy, which some of you may have tried. I don't know. It is a gene therapy which was applied into the muscle with really many injections, and the effects on triglycerides, which you see here, was really not very impressive. Here you see at 8 weeks they go a little bit down, and then they go a little bit up for 2 or 3 years. It's not longer available. It's discontinued. It was hell expensive, and patients had to have immune suppression and all the things. But there's one thing I want to show you, which is for me really important and exciting, that even though the triglycerides went not really down for a long time, you have some reduction of pancreatitis. Here you see the same time frame before the gene therapy and after, and you see less pancreatitis in the patients after treatment than they had before. Abdominal pain also. So this shows, and this is maybe one of the important points, that very little changes in lipid metabolism really may change a lot in terms of pancreatitis. And the other point why I'm excited about the therapy, although it's no longer available, it was the first gene therapy which was approved in Europe. And in the Western world, actually, there was something in China going on, but in Europe, it was the first approved gene therapy. And this is, for me, it shows how important FCS is, also in science and for pharmaceutical companies, that there's really a therapeutic need, that the European Union, the Commission said, okay, yes, we do the first gene therapy, especially for this rare disease, for FCS. So this is very exciting. Now, the presence, of course, is another one, and now we're getting back to ApoC3 and volanesorsen, of course. And I want to get back to you a little bit to the mechanism. I'm sure most of you know this. You have DNA, and the DNA produces messenger mRNA, messenger RNA, which is kind of a messenger, as the word says, and this then produces a protein. And our most effective therapies right now, including ApoC3, act here at the mRNA. And what they do is, our medication binds somehow to this mRNA and degrades it. So it does not make any protein. No protein can come. This is highly specific for this gene. So we reduce the gene expression, and it's vector-free. It's no virus in or something. It's hepatic uptake, and it's not a gene transfer. Gene transfer would be if it would go into the DNA. It really acts only on the protein levels, kind of vice versa to our immunizations against COVID, which is kind of a comparable mechanism. Now, and to reduce a protein production, currently we have two ways. One is called antisense oligonucleotide, and one is called siRNA. And the action, roughly spoken, it's the same. The antisense oligonucleotide goes in, binds to this messenger RNA, degrades it, and the protein cannot produce. Here we need another step, as siRNA goes also in, has to be somehow changed into an antisense strand and needs some proteins to act. But at the end, it's the same. The protein production goes down. And now that's why I showed you the pathophysiological slide with ApoC3. Now, what we do is we reduce ApoC3, and with that, we reduce triglycerides. And this seems to be right now the most effective way to treat FCS. And you know all these slides. And this is, of course, volanesorsen with a real nice and strong triglyceride lowering. These are data from phase 2, I think, or phase 1 or 2 study. And this was a basis for the approval that we can use this drug today. Now, I do not want to go into side effects. Time is short today, but I want to show you one more slide for volanesorsen, which, from my feeling, is very exciting. So this is a follow-up from several groups of patients from the studies, and the people here were looking onto pancreatitis, and they do the same. Because you cannot really use a control group for these patients. That's why they always compare patient pancreatitis before treatment and under treatment. And here you see before treatment in this group, 33 patients with 82 pancreatitises in 5 years. And after, put it a little bit together, only 5 patients with 5 pancreatitis per 2 years. Now, this is really less, and this is really a success of the treatment. Now, this proves not everything, but that's all we have, and it shows something we are doing correct with this treatment. And I think that's a really good step on our approach to treat this disease. Now, where's the future? And it's still inhibition of ApoC3, which is the most promising thing right now. And this is the substance is called olezarsen, It's always difficult to pronounce for everybody. I do not understand who makes those names. And what's exciting about this? It's an antisense oligonucleotide, so somehow the same as volanesorsen, but as it has one change. It has a little guide here, which helps the substance to get better into the liver. It uses a special receptor. This is too much detail, but by doing so, but having this little thing here, acetylgalactosamine, this is galactose basically, which binds to a special receptor of galactose, and via this receptor it can really easily go, or easier go into the liver than volanesorsen. At least we think so. And so we think that we can use lower concentrations than volanesorsen, and so you have less reactions like flu-like reactions. So far, no platelet count changes. So this is exciting. Data are still limited, is in phase 3. It's not yet approved, but it's kind of the same. You see here, D it is whereas triglyceride, B is triglycerides. So the triglyceride lowering is really comparable here, 50 to 70%. So this is exciting. Using an equal drug but in a lower dose with the same effect is always good in terms of side effects. So this is what's coming on, and I'm very excited whether it will be approved and how it will work with our patients. And then just to show you, there's not another way. I showed you that short interfering RNA is also a way. This is still very early in development, but it's also a way to reduce ApoC3 and by that reduce triglyceride levels. Here the triglycerides are down here, 80% reduction of triglyceride levels. We see what works out best at the end, but this is really phase 1 or 2. It's really very early, so it will be not easily available. Now, the other way is inhibition of HPLT3, and this antibody against HPLT3 is very interesting, especially because we know that people who do not have HPLT3 genetically, they have very, very low triglycerides and very low cholesterol. And this antibody against HPLT3 is really very effective in FH. I'm sure you heard about this. And the data are very, very good, and it's approved, evinacumab, for familial hypercholesterolemia. And it was the hope that it might also work in FCS, but the data are shown here, quite new data actually. It does not work at all. Here blue is placebo and red is evinacumab. It doesn't work. It works in other high triglyceride situations, but not in FCS for whatever reason. I don't know, but this is not a chance. Now there is, however, and this is almost the last slide for today, there is in development an siRNA, which is still in phase 1, so it's very early, because phase 1 is always the earliest phase, going to humans, like first in human. The siRNA against HPLT3 it seems to be, at least in healthy people, effective in reducing triglycerides, but so far I'm not aware of any data in FCS patients, so we have to see. So, coming to the end, summary: FCS. Severe HCG hypertriglyceridemia can result from chylomicronemia and from multifactorial diseases. I showed you FCS is, of course, a severe disease leading to acute pancreatitis and to other symptoms. We definitely need new effective therapies, and this was already shown with the first gene therapy approved in Europe. Present, we do, besides diet, of course, volanesorsen, and the future might be also another ApoC3 inhibitor and maybe other drugs. Thank you for your attention, and of course, I will stay with you. So please ask questions or give comments.
Excellent. Martin, thank you. That was very clear, and it was really interesting for me as a patient, and I'm sure for the others, to actually understand a little bit more about what these therapies do and what their, what the mechanism is. So thank you for that. there is one thing to say about volanesorsen, which is not available everywhere. So not all patients with FCS can get it. And also,
what can you say? US, it's not?
It's not available in the US. No, it was denied. FDA didn't approve it.
Because of thrombocytopenia, probably.
Yes, because of the side effects. But also, it does mean that some people can't take it because of the platelet counts. So it's not an answer for everybody, I think, is
I see. I was not, sorry, I was not aware of this.
Yeah, and also you do need to keep to the very low fat diet when you're on it. So it isn't for patients, it actually does do a lot with the kind of symptoms, but it doesn't actually change the kind of difficulties of living with the condition particularly. So while it's a benefit, and it isn't the dream of being able to go and eat what we'd like. So, but that is a big improvement. Anywho, thank you for that. So now I'd like to spend some time talking about the patient's experience with FCS, and I wonder if I can ask you, Michelle, to just introduce yourself and tell us a little bit about your experience leading up to being diagnosed with FCS. Thank you.
Sure. Yeah, fancy having to follow such an expert. Okay, so I was diagnosed quite late actually with FCS, only last year actually. I'd always had issues with bloating, heartburn, being quite nauseous after eating things that were high fat, but nobody ever sort of put those things together. Probably in the 10 years leading up to the diagnosis, it had been noted that I had ridiculously high cholesterol, high triglycerides, and I was treated with statins and fenofibrates, which actually I think they're quite high risk to have together, and they had really, really very little impact at all. The levels of anything didn't really change very much, and I took them together for quite some time. And then I think in November, December 2021, I had my first experience of pancreatitis, which was truly horrific, actually. It wasn't recognised as pancreatitis first. I was sent home from the doctors saying that I had gastritis and I should just rest. When I finally got into a hospital a week later, I then got a real telling off from a consultant, because pancreatitis is very serious and you shouldn't have waited a week to get here. But, you don't know. I was questioned about alcoholism or how much alcohol. And it seemed by every professional that I spoke to, even though I actually don't really drink, very, very rarely, but that seemed to be a real big thing. Drinking. So I was in the hospital for about a week, but it really wiped me out for quite some time, actually, even after I came home. I was given some dietary advice, which was probably appropriate for somebody with high cholesterol. It just contained details of like healthy fats and things like that to eat, which of course, had I known that I had FCS, you'd know no fat's really healthy fat. So yeah, things like get yourself some avocado. That makes me incredibly ill, gives me really bad stomach pains. Obviously, it's got quite a high fat content. So not surprisingly, 2 months later, in the February of last year, I ended up back in hospital with a second bout of pancreatitis. The hospital were aware of, like, and I mentioned several times, I had high triglycerides. This was something that I was seeing a consultant about. But they didn't really entertain that too much. And they seemed quite concerned that even though MRI scans showed that there was nothing wrong with my gallbladder at all, they might just take it out just to be on the safe side, because they weren't really sure what was going on with me. Luckily, they didn't do that. And I did get to see another consultant, an endocrinologist, who had just coincidentally a little bit of experience of a patient with FCS, really, really fortunately for me. So he's suggested that I'd be tested for FCS. It took about 8 months for the result to come back. I did see his dietitian, but really low fat really wasn't actually not explored to the extent that it needs to be. And it was really, really difficult to get any dietary advice at all. Even after the diagnosis came back that I had FCS, I was just told to go away and look it up, go and have a look on a website. I was a little bit thrown, actually a little bit shocked that I even had this. So to then have to go away and do your own research, you know, and that was all there was really. Very luckily, I was referred to a rare disease hospital with a view to putting me on volanesorsen. And actually that's where the learning started. I had a nice team of nurses that came around that put me in touch with the Facebook groups, with Jill, with some other people experiencing the same thing that I could learn from. And actually I've learned more from them, from the websites, than I have from any doctor that I've seen, any consultant that I've seen. Actually, most of the information that I've had has come that way. A dietitian that I was sent to, actually, I was really hopeful I was going to get some good advice, but she actually brought a notepad in to take notes from me, which wasn't great because I didn't have a clue, and it was like the blind leading the blind. Until very recently, when at the actual rare disease hospital, they did actually have a specialist dietitian who actually I think also probably learned quite a lot from Jill too. But actually that was the first time, and that was probably about 6 weeks ago, that somebody actually sat me down and explained what chylomicronaemia actually was, because I had no idea. It was just a big word that I couldn't pronounce. What was happening to my body, and therefore help me manage what I was doing, because I knew actually what was happening. But that really has been only very recently. So it's been quite a long journey. Although I think actually when you listen to Scott later, my journey has been a lot easier than his has, but it is still not great. I think that's everything, Jill.
Thank you, Michelle. Sorry about that. So thank you for sharing that, actually. And I mean, what I was putting out of there was that the lack of education and information and the lack of dietary supports, and the kind of being sent off to sort of do your own research and finding other patients, and that's where your support comes from, really, and your information. So I'm pleased we're there for you, can I say?
Thanks.
So thank you. So yeah, Martin.
May I comment on that? Thank you very much. Your story really tells the story of several of my patients, and I want to point out two really important things which you unfortunately mentioned. First of all, it's a story of pancreatitis. Every physician thinks pancreatitis is either gallstone or alcohol, and gallstones, it's easy to be ruled out, and then comes alcohol, and that's really a big problem. And I was thinking about starting with this patient history, a patient who was in hospital, and the physicians there, they look for early cause of pancreatitis, but not into triglycerides. And even at their discharge note, it was kind of, they couldn't really believe that it's triglyceride, but they didn't find anything else. They didn't give any therapy, but they really couldn't believe that it's triglyceride. Not taking this, it is not a common cause, but it's probably the third most common cause of acute pancreatitis. So, and it has nothing to do with alcohol, and you should just, I don't know, punch your physician or something. It's important. Yeah, it is a reflex. It's the same with liver disease. People suffer a lot.
So Martin,
And the other point.
Sorry, carry on. Yeah.
I just very briefly. And I really, I know the story with the dietary counsel, and FCS is nothing for a normal dietitian, and this is the same in Germany. Nobody can do this, and we have in Germany, I would say, like 3 dietary nurses who really would be able to do this. Just
thank you.
So thank you very much.
Yeah. So actually moving on to, as you say, Michelle, moving on to Scott. Scott, you want to share your experience of diagnosis with pancreatitis, with FCS, I beg your pardon.
Sure.
And so please, yeah.
So my experience is a little bit different. I was having pancreatitis about once, going into the hospital once every 8 or so weeks. And the doctors in the intensive care saying that I was just there for high doses of pain medicine because I was a pill head, and I was an alcoholic, and how much was I drinking? I had one doctor actually send in an alcohol mental health person because he didn't believe that I was telling the truth, that I didn't drink a bit of alcohol. As a matter of fact, I don't even do mouthwash that has alcohol in it, just so that when I'm asked, I can say I don't do any alcohol. So my triglycerides at the highest point were 24,000. And thank goodness I've got a doctor that is willing to help and listen and kind of think outside of the box of treatments, because that injection is not available here in the United States. So we've kind of got to think outside the box and on some things. So I was diagnosed late in life. Well, I say late, I'm 44. And so not as an infant. I've been dealing with this since I was 24, so about 20 years. Now, I have gone through dietitians. I have gone through health insurance companies trying to tell me how to live and how to do my diet, and to the effect of, thank goodness I had my own research, that when they say things, I was like, that just doesn't work. That doesn't work for me. You're not listening to what I'm telling you. I have to stay under 10 milligrams or 10 grams, whatever. And they're like, well, avocado, you can do avocado. No, ma'am, I can't. Okay, please don't say that again. I'm going to hang up on you. I don't mean to be rude, but you're not listening to me. And I think that that's a symptom of a lot of the people that I have had dealings with, is that they just don't want to listen, and they don't want to realize that they don't know. They're trying to be the hero. And last time I was in the hospital, I just had to say, look, I don't need you to try to be a hero. This is what I need you to do for me. Hook me up and do this. And so when I do get pancreatitis, flare up, as I call it, I go to the same hospital. They know me there. And luckily, thank goodness, over the last couple of years, they've grown to know me and see me out in the community. And so that's been helpful. But there's always that one person that just wants to be a hero and save me from myself. And so I think that I am diabetic. I have been diagnosed as type 2, but my pancreas is stopping producing any insulin. It produces a very, very, very small amount of insulin. So I don't know the medical way of talking about this, but I'm going from a type 2 diabetic to a type 1 from what I understand. I don't understand it all, and that's very limited. And so I've tried all the medicines. So I do wear an insulin pump all the time for this, and the insulin does help bring down my triglycerides. I go every 2 weeks for an IV injection. to help with that as well. So, I just think that the lack of respect and for people, just because the doctors don't know and don't understand you, they just kind of think of you as a challenge. And I'm just not anyone's guinea pig, and that's hard. And my last story that I'll talk about my diagnosis and trying to figure it out. I live in North Carolina, which is kind of right smack dab in the middle of a lot of research hospitals, big research hospitals in the United States. Duke, UNC, UNC Healthcare, Baptist Health, lots of big research hospitals. So I was seeing the head of endocrinology at Duke, which is, he's a big deal. So my doctor's appointments, my 30-minute appointments would last 5 and 6 hours, because he would go into the hall and tell all of the medical students that were walking by, hey, come in here and look at this guy. You don't see triglycerides this high in people that are living. And so that was quite the experience, having all of those medical students. And I finally just had to cut him loose. And so that's kind of a little bit of my experience with FCS.
Thank you, Scott. And that's a very kind of powerful experience about lack of awareness of the condition and lack of, as you say, listening to the patients about what they know. And again, this awful experience, which I've heard time and time and again, of being treated as if you're drug seeking or you drink too much. And that's, you're bad enough that you're in such pain, but then to have an accusation of fraudulence, as it were, must be terrible. I say must be terrible. I'm fortunate in some ways, because my experience of FCS is actually quite different from both of yours, because I was diagnosed at the age of 2. So I've always known that I've had FCS, and I have to say that that's both good and bad, because I've grown up feeling immensely difficult around food. Not comfortable with food at all, just kind of feeling guilty half the time if I wasn't eating the right foods. I was eating the wrong foods. I had multiple really bad stomach aches, which would last for 5 days, and I'd lock myself in my room and not eat anything, and just take painkillers, which, I'm not sure they were pancreatitis, but they were very, very painful. But I wouldn't go to see a doctor because I'd brought it on myself. I'd done it to myself. So I was kind of, didn't want to kind of bother anybody, because I knew exactly why it had happened. So looking back on that, that's a bit silly, really. But that's how I felt about it all, because I very much was kind of brought up to, you're all right, you're fine, just don't eat this, don't eat that. And actually, as a child, especially, that's really difficult. And the other issue I found was that I didn't have an instant reaction to food, but it would build up slowly. So it was the thing about the opposite of deferred gratification, because I'd be able to eat something and think, well, I'm fine. And then suddenly I wouldn't be fine. And that was really quite tricky to negotiate. I did actually manage to kind of get some degree of kind of management of my diet as I got older, largely due to the fact that I married somebody who's a fantastic cook and took me under his wing. So taught me how to eat properly, really, actually, because I don't think I'd learned how to kind of have a diet that contained everything you need, and also keep low fat. And bearing in mind, I grew up in the 60s and 70s when there was no nutritional analysis. So it was actually very difficult to manage. But then my difficulties started again when I became pregnant, actually, because there was not very much, well, in fact, there was no information out there for pregnancy. And then I developed diabetes, my second pregnancy, and saw a diabetic nurse who said to me, if you're hungry, eat nuts and seeds. And I said, well, I don't think I can do that, actually. And I left that kind of consultation feeling quite angry and actually quite on my own, that it was, if I was the one who knew more about this condition than anybody else, it felt. And I hadn't really got that much support from the medical, there was nothing my medical team were doing, really. That changed when I got diabetes, actually, to having somebody from the endocrinology section who really was kind of very sort of supportive of me. But it was at that point where I thought, right, we need to have something, because there's nothing out there for patients, really nothing. The only kind of information you could ever find was kind of dry medical things about pancreatitis, numbers of pancreatitis attacks, nothing about shame, guilt, pain, abdominal pain, isolation, all of those things, which was what my life was like, really. So anyway, that's what sent me to set up the charity. I just wanted to say that that's why the charity was there, because I wanted so much for patients to have, or I just wanted everyone to be able to have some kind of information and be able to kind of at least have some support around them, and also to raise the patient voice, because I was also involved at that time through a series of other things in advocating for new medicines. And I was in touch with I was into the sort of system of being the patient voice for in regulatory meetings, and it did really occur to me that as an individual, I had far less clout than if I was a group of patients. So and as a group of patients with the same voice, it's much louder. And I think that's a really kind of key thing for moving forward, really, that actually patients need, especially in rare disease areas, need to be groups of patients in order to have a stronger voice to get it heard and get their needs met. So in terms of needs met, actually, do either of you have any kind of unmet needs that you feel that could be addressed, that haven't been addressed so far, that would be supportive to you? I don't know if Michelle or Scott.
I still feel like really diet, like I say, I'm still very new, I'm still trying to get the hang of it, but I still feel that dietary advice would be good. Potentially the other thing is, I still haven't, even though we all get together, I still haven't found anybody else that's taken the volanesorsen. So although I have a team of nurses, I administer the injection by myself once a fortnight, and I struggle with that a little bit. Sometimes that is really hard, and not every time, but most times I react to it quite badly, and it's just a really difficult thing to do, and it'd be really good to, I don't know, talk to some other people that experience that as well. They may very well have some tips or something that might help with that. The nurses can only do so much. Really, somebody with the same or similar sort of experience would be really helpful, I think.
That is something I can help you with, actually.
Thank you.
Yeah. Scott, did you have anything that you wanted to raise as an unmet need?
I think just the sheer mental health support of dealing with something that no one else or very few people are dealing with. Just the support of feeling like you're an island and feeling like you're just out there by yourself, and actually the feeling of being not normal, and being okay with that. I mean, even I still struggle with that of having to do things differently than other people, and having to hear people say, well, one bite won't kill you, you can at least taste it, talking about food. And so the mental health aspect of having a rare disease, and that takes a special therapist, a special mental health person to even understand that, and to help me work through that diagnosis and through being not normal.
I would second that, because I could have done with a lot of mental health support, and occasionally still do, because actually, even though I feel like I'm living quite a kind of steady life, I do actually I don't join into lots of things in order to not be put into situations where it's risky for me. I don't do that. I don't travel around very much because that's difficult. So mental health is a big one for me as well, actually. And also there's a lot of kind of research questions out there that I would be interested in learning about, in terms of the impact of whether CVD or heart problems are related to, because there are patients in the community who've had heart attacks, and we don't know whether that's to do with the FCS or whether it's some other reason. We just don't know. So that would be really useful. There's other stuff about what's what impact does the menopause have on us as patients, and aging generally. I'd be really curious about that. And also I think it's about 25% of patients get diabetes, and I'd really love to know whether there's any kind of evidence to show which patients are at greater risk of getting diabetes, and whether that could be kind of managed beforehand to kind of stop that, because I also have diabetes, and adding that extra bit of diets to the diet that I already keep is tricky. I mean, it just limits things even more. Anyway, so I realised that the time is going by, and that one of the difficulties for me about moderating something like this is that obviously I could talk about it until the cows come home. So I've got a lot to say. But I just wanted to look at the questions and see if there are any questions. We do have one question, actually, which is, does the treatment vary from country to country? And if yes, are there huge differences? I don't know, Martin, does that something you could address?
Well, I'm basically working in Germany, so I can refer basically to Germany. I think the most important point you already mentioned was available of medications. So obviously the European Union is a little bit easier in accepting orphan drugs. We call those drugs orphan disease, orphan drugs, as you may know. And Volanesorsen doesn't. I don't know in which countries this is available. The second thing was mentioned also here, and I think this is what we do in Germany, not as good as in the UK, for instance. You need to have specialized centers, and it's just very difficult in Germany. It's a big political issue, and whatever I hear from, for instance, Netherlands or from the UK, or even some cases from France, it's easier to end up in a specialized care hospital and then get the proper support, including psychological support, or mental is much better, mental support, meet other people, and so on. And this is a big difference. So the patient story may vary a lot from country to country.
Thank you.
Maybe this.
Yes, I think that's right, actually. And actually, the introduction of specialist hospitals in the UK has only been in the last couple of years, and that's been very specifically around the.
It's very good, and
yeah.
I'm generally not only a fan of the British healthcare system, but for rare diseases, it's a much better place to be than for instance, Germany.
Yeah, well, that's good to know for two of us on this panel. Well, thank you to the three of you for your input. It's been really, really interesting and insightful, I think.
That's a comment. Yes, the British healthcare still has a way to go, though. Yes.
Yeah. But so I just wanted to sum up, really, that we've been talking about the importance of specialised centres for managing this condition, the need for information and awareness, and bearing in mind that Michelle is in a specialised centre, there's still a great deal of information and dietary support, and just kind of knowing, I guess, and talking to others, really, I think, is really important. And research, we were talking about mental health supports being, I suppose if you're in hospital with pancreatitis, that triglycerides would be recognised as an issue to cause pancreatitis. That's another big unmet need, really, because many patients have reported this issue when in hospital. So lots of things that could go forward to improve the situation for people with FCS. And I think probably underlying all of those is the need for awareness that for the people, everybody out there, including physicians, to have heard of FCS, so that they consider it as a potential when they're dealing with somebody who's having the symptoms that we experience. And Michelle, you had a very, very fortunate experience of meeting the doctor who just met another patient who then got you tested, because you may well not have a gallbladder anymore if that wasn't the case. So that was a big kind of serendipity for you. In terms of raising awareness, I just want to come back to our FCS 10-gram challenge, and we've been doing it. And as you see here, this lovely photo of Martin, who very kindly and very bravely is going to give us a go tomorrow. So we're going to do a call to everybody on this webinar for you to take the FCS 10-gram challenge, and you'll find more information about it on the Action FCS website, which is actionfcs.org, and on the FH Europe website, which is fhef.org, in the news section. So please do have a look at that tonight and have a go tomorrow. And if you find that you can't, at least have a sense of just what fat is in the food that you're eating during the day, because you'll find that you'll be very surprised that even a slice of bread can vary widely. It's not as simple as you might think. So to wrap up, the next webinar that we're doing is another one about FCS. Well, that will be looking at tips and techniques for cooking with FCS, and it will be a practical workshop. And Emma, who's my colleague from FH Europe, was also a chef on luxury. I'm going to get this wrong, but she used to cook on luxury yachts, I think. Oh, she was 12 years a chef on super yachts. Thank you, Emma. And so she's going to be cooking with my guidance and my input. And then we'll have Professor Kirsten Holven with us, who's a nutritionist. I think that would be an interesting one to have. And we debated whether we should do that before the awareness day, but decided that most patients don't get that luxury when they're diagnosed initially. So actually, we should try it first and then perhaps get some tips and techniques. The last thing I wanted to say actually was that this webinar will be available tomorrow. And thank you for your participation. And these webinars are all available on our YouTube channel. And you'll see that the previous 3 webinars are all available there now. We know that this one will be put up tomorrow. So thank you very much, and we'll leave it there. Thank you.
Okay. Thank you very much. Bye-bye.
Bye.
Thanks, Jill.